Okay, good afternoon. Thank you very much, Danny, for the invitation to come here. So, my name's Anthony Harries, Tony Harries. I work for the Union in Paris, France. I also have a position at the London School of Hygiene and Tropical Medicine. So I'm going to actually look at the public health and programmatic aspects of diabetes and TB, so take you a little bit away from the cells. And what I want to do in 15 minutes or so is very briefly tell you about the interaction again between diabetes and tuberculosis, tell you what the global response has been to that interaction, and then take you to India and show you how in India we've been trying to implement bi-directional screening within routine health services and discuss some of the challenges that have evolved. So for me, interestingly, the real interest in this story was about 8 or 9 years ago, although this has been known about way back, in fact, Roman times, classical times, I think. But two key publications, one by Catherine Stevenson and colleagues from MRC and WHO, and then the following year by Christy Gion and Megan Murray from Harvard University in the States. Both of them systematic reviews, meta-analyses, slightly different time periods, and both studies concluding that diabetes, as Danny said, increases the risk of tuberculosis by a factor of 2 or 3 times compared with normal people. Now that has been confirmed in subsequent studies. There's also growing evidence that in people with diabetes, poor glycemic control further increases that risk of tuberculosis. And just this year, a publication from Taiwan showing that again, in persons with diabetes, enhanced case management, good diabetic control mitigates and lessens that risk of tuberculosis. Does this interaction matter in terms of global public health? And the answer is an emphatic yes. We have a global diabetic pandemic, cases escalating, particularly in Asia, particularly amongst the urban poor. So we will expect to see increased numbers of patients with diabetic-associated tuberculosis. We also know that in diabetic persons we have worse TB treatment outcomes. There's evidence of increased risk of failure on treatment, increased risk of death on TB treatment, and increased recurrent disease. And a nice systematic review by Megan Baker and colleagues published in 2011. Now, in terms of the interaction, in August 2011, the WHO and our organization, the Union, launched the collaborative framework for care and control of TB and diabetes. And basically made recommendations around 3 main themes. Firstly, that we need to establish mechanisms of collaboration between the NCD world and the communicable disease world. Secondly, to detect and manage tuberculosis in patients with diabetes, and of course to detect and manage diabetes in patients with tuberculosis, so-called bi-directional screening. Now, at the time this was launched in August 2011, precious little evidence about how in the routine setting we should do this. So with some support from the World Diabetes Foundation, we set up working in routine health services in China and India. And I want to take you through what happened in India. Now, I think the structure of how we did this is really quite important. So let me very quickly go through it. We started with a national stakeholders meeting. WHO, the Union, the World Diabetes Foundation, the director of the National TB Program in India, the director of the National Non-Communicable Disease Program, key people from Ministry of Health, key academics, around the table to discuss, was this interaction of interest? The answer was yes. How were we going to, in routine services, screen people bidirectionally for both diseases? How are we going to monitor, record, and report our findings? And above all, where were we going to do this work? So having agreed on that, we trained the implementers, we implemented the screening over a 9-month period, we brought everybody back, reviewed the activities, reviewed the data, and then reported back to national stakeholders. If you want to get policy changed, that's a very good structure to try and get policy changed. So let's look at screening diabetes patients for TB. Very simple. Generally, diabetic patients in India and in China come once every 3 months to a diabetic clinic. So we can ask a very simple question: in the last 3 months, have you been diagnosed with TB? If the answer is no, let's screen those diabetic persons for positive symptoms of TB. Have you got a chronic cough? Have you got fever, night sweats, weight loss? And if anyone has positive symptoms, you refer for TB investigations. So this shows you in a number of diabetic clinics in India for the second quarter of 2012 the results. 12,000 diabetic patients seen. 74 of those people said, I have been diagnosed in the last 3 months with tuberculosis. India has a very good TB DOTS program, and they were diagnosed in one of the TB DOTS centers. That left for a remainder who should have been screened, and I think, as you can see, this didn't work very well. Only half the patients were asked those very simple 4 questions. Only a very small proportion had positive symptoms. Most of those were referred for TB investigations, and just under 10% were found to have tuberculosis. So the yield, if you like, from this exercise, routine services, was 85 patients diagnosed with tuberculosis, which gives you a TB case rate per 100,000 diabetics per quarter of 695. That actually is very high, much, much higher than you pick up through routine passive case finding in that amazingly large country. But big challenges. First of all, quite clear to us, diabetic doctors not interested in doing this. Too much work, we don't want to get involved. We know that screening by smears and chest radiography has poor sensitivity. There are challenges with extra pulmonary TB because those 4 questions focus on pulmonary disease. And above all, in diabetic clinics, there is no public health system of monitoring, recording, and reporting on cohorts of patients, in complete contrast to what goes on around the world in TB control. We also need to know, is newer TB technology cost effective? Should we be using this new machine, Expert MTB RIF? How often should we screen? Is 3 months too frequent? Should we do this every 6 months or maybe annually? Should we use a more targeted approach and just go for diabetics who are at risk of tuberculosis? And finally, should we screen for latent tuberculosis? WHO at the moment recommends against this form of screening. Some new evidence in the last year, some evidence that the risk of tuberculosis appears to be higher 1 to 2 years after that diagnosis of diabetes has been made, probably because people are out of control at that time. And then the risk of TB is higher in those, not surprisingly, with greater TB exposure. So, for example, diabetic persons who are healthcare workers are at higher risk, those with poor glycemic control, and those, interestingly, who are heavy smokers and who have heavy alcohol consumption. Let's look at screening the other way around. So this is your TB patients now being screened for diabetes. So how does this work? So here you register your TB patients and you very simply ask, are you known to have diabetes, yes or no? If the answer is no, then you screen first with a random blood glucose. If that is at or above 6.1 millimoles per litre, it means people are at risk of diabetes, and you need to bring them back to screen with a fasting blood glucose. And if that is at or above 7, you can diagnose diabetes and refer to care. So again, let's go back to India. This screening was done in 60 health centres and 8 district hospitals over an 8-month period. So 8,000 TB patients registered in this time. 8%, as you can see, already had a diagnosis of diabetes, and the rest needed to be screened. And this worked very much better than the other way around. You can see that 98% of patients got a random blood glucose. Of those needing a fasting blood glucose, 95% got it, and basically 402 newly diabetic patients were identified through this approach. So with this exercise, identification of over 1,000 patients with diabetes who also had TB. So very good. Now, this was presented at the national stakeholders meeting and had an impact on the people who make policy in India. And there was an immediate policy decision, an immediate directive made that has cost implications, that in India, henceforth from September 2012 onwards, all TB patients are to be screened for diabetes, essentially using glucometers. Now that has big implications. First of all the TB treatment cards in India had to be changed so that at the bottom where there is here HIV status, they have to put in parameters about diabetes status. The registers that people use in DOTS TB clinics, the right-hand side, had to have a new column here to indicate information about diabetes. And the quarterly TB reports now also have to include information about who has been screened for diabetes and who has been diagnosed with diabetes. Of course, I think you're probably aware that policy to practice takes a little bit more length of time. So if you look at the northern part of India, the central part of India, this has not been rolled out implementation-wise very well. But in the southern part of India, not bad. So I provide you with some data from Kerala state in South India over a 4-year period. In green are the number of TB patients registered each year in that state, and in orange and in the percentages are the number and percentage screened each year for diabetes. So things have ratcheted up in that state, going from 27% of patients being screened up to nearly 90% of patients being screened. So Kerala has moved quite well on this screening. And the pickup, not bad. 24% of TB patients had diabetes in 2010, and this has plateaued at around about 18 to 19% for the next 3 years. However, there are some challenges. I think this has already come up. When is the best time to screen? Should we screen TB patients at the time we register them, or should we wait until the end of the initial phase of treatment, that's 2 months, or maybe until the end of treatment? And the issue here is that tuberculosis is a chronic infectious disease. It causes chronic inflammation, it puts stress on the system, and that raises blood sugar levels. So you can make a false positive diagnosis of diabetes. The problem is if you wait too long, you miss the opportunity to pick up diabetes and do something about it. And then on the right-hand side, how to screen. Should we do it clinically? Should we use a very simple urine dipstick? Should we do a random blood glucose, a fasting blood glucose, a glycated hemoglobin, or an oral glucose tolerance test? Now, as you move from top to bottom, those tests become a lot more specific and a lot more sensitive. But the problem is they become more cumbersome to use and they're a lot more expensive as you move particularly to glycated hemoglobins. So in a routine health service, you have to strike a balance of what can we afford, what can we best do. In terms of treatment, a few challenges, let me just throw them up here. All patients with TB, drug-susceptible TB, get 6 months of treatment. Is that adequate if you have diabetes? There's some evidence that it's not, and we should be treating with 9 months. What are the best drugs? We know, for example, that rifampicin interacts with sulfonylureas to lessen the concentration of those drugs and therefore make diabetic control worse. What about toxicity? We have drug-drug toxicity. Isoniazid, metformin combine to increase the risk of lactic acidosis, which is potentially fatal. Isoniazid and diabetes both cause peripheral neuropathy. What about TB infection control in diabetic clinics? If we've got TB people sitting there, we know next to nothing about this. Recurrent TB, I think Danny, you brought this up. Is it due to reactivation or reinfection with a new strain? Can we, in busy TB clinics, if we're integrating care, do anything about lifestyle modification with advice about smoking, diet, and can we in fact integrate care? So some new evidence, some work being done in Singapore, interestingly, showing that metformin, which is an old established anti-diabetic drug, has some effect against Mycobacterium tuberculosis. Some work in Mexico showing that 20% of recurrent TB in that country is due to reinfection with a new strain of Mycobacterium TB. So where did people get it from? From the community in which they live, or did they pick it up from their diabetic clinic. And finally, Lin Yan, my colleague in China, went round looking at 10 diabetic clinics in that country, finding totally inadequate infection control measures, particularly with regard to airborne transmission of infection. And in terms of program integration, I'm afraid if you have both diseases, what happens is you go to a TB clinic for your TB treatment, and then you have to wander along to a diabetic clinic for your diabetic clinic. Surely we can integrate this. And in Mexico, they did. They integrated diabetic care into the TB clinics, trained the people there to manage diabetes, and got much better clinical outcomes and much better treatment success. So we really need a lot more research, a lot more funding, Danny, on this. So a couple of my last slides. I'll bring up the Tandem Consortium. As you said, Danny, this is an EU FP7 funded consortium led by the London School and led by Radboud University in the Netherlands, doing great work. They're doing field work on bidirectional screening and on treatment of people with dual disease. I think it's in Peru, Romania, South Africa and Indonesia. And they're working a lot in the laboratory on biomarkers, on T cells, monocytes, macrophages, adipocytes, doing genetic studies, trying essentially to unravel what is causing this link between diabetes and tuberculosis. So I'd like to end with my last slide here. In November last year, about 120 of us met in Bali, Indonesia. These were high-level people from government, from NGOs, from industry, advocacy groups, civil society groups, research institutions, to essentially say, we've got a problem here, let's try and do something about diabetes and tuberculosis. So an agreement that we would accelerate implementation of the collaborative framework for care with advanced policies. Importantly, we would update and support a robust research agenda that builds upon a previous research agenda. And I'm pleased to say that the NIH are convening a meeting in May, Danny, in Washington, where we'll really look at this and see if money cannot be made available to look at diabetes and TB, but also a wider framework. I think we need to think about how the non-communicable diseases can link up with communicable diseases, because it's not just one-on-one. I think this can be multi-morbidity, as we've heard very nicely about melioidosis. So thank you very much for your attention. I'm happy to answer questions later.